Dr. Wong for that introduction. I'll be talking about our consistent OR teams, a pillar of patient safety. I thought I'd start with a case vignette. And the situation, a locums anesthesiologist is covering an overnight in-house call when she's told a post-neck dissection patient with an expanding neck hematoma is coming emergently to the operating room. The patient's wheeled down by the ENT team to the operating room where the nursing and anesthesiology teams are setting up. The anesthesiologist turns to the surgeon after evaluating the patient and requests that the neck incision be open prior to induction. The ENT surgeon says, "No, just induce and intubate. It'll be fine. She was an easy airway this morning." When the locums anesthesiologist suggests reconsidering opening the neck incision, the ENT surgeon says, "Why don't you just push the drugs and we can intubate if you don't want to?" The anesthesiology team induces and is unable to ventilate or obtain an adequate view with video laryngoscopy. The surgeon takes over and intubation ventilation attempts are unsuccessful. The patient has a hypoxic arrest. An emergency tracheostomy is performed with about a liter of blood loss with subsequent ROSC. Both teams point fingers at each other when debriefed by their patient safety directors and file hospital event reports with conflicting accounts of the events. So I'm sure we can all agree that we've witnessed similar uncomfortable situations. There's certainly elements of the situation that contribute to overall dysfunctional team dynamics, possibly affecting the patient outcome. For one, the two physicians were unfamiliar with each other, which meant they were also unaware of the extent of the skills the other possesses. In the moment of an emergency, there's some uncertainty also for who's the team leader, who's prescribing the plan, and potentially even conflict over the best course of action. One physician may be a part-time physician, while the other is maybe a full-time faculty member, which may impact power dynamics and the willingness to speak up in this moment of crisis. A well-known patient safety expert named Jeff Cooper once wrote that while the relationship of the surgeon, nurse, anesthesiologist, and others in the operating room are critical to ensuring safety, effectiveness, and quality, the relationship and interactions between the two physicians who sometimes share, yield, or compete for leadership has a power to enable or thwart success that may transcend that of other interactions. Jeff Cooper proposed that the relationship in each surgeon anesthesiologist dyad is perhaps the most critical element of team performance. That a well-functioning relationship is conducive to safe, effective care, and that a dysfunctional relationship can promote unsafe conditions and contribute to an adverse outcome. Yet when Jeff Cooper wrote this in 2018, there was actually very little evidence and research about this relationship and what could be done to improve it. But he did suggest that optimizing the surgeon anesthesiologist dyad performance could be accomplished by working in fixed versus changing teams. We see a good example of this in sports, so particularly in Olympic basketball, where the greatest NBA players are brought together on the USA Dream Team. And they may face strong competition or even be beaten by, say, an Argentinian team with much less talented players when considered individually, but who may have grown up playing together and exhibit what we consider to be critical team behaviors. These are, individuals who perform well together as a team often display good communication, adaptability, coordination, and cooperation, team spirit. Ineffective teams may have superior talent individually, but often don't fare as well as the effective ones because of the lack of these critical team behaviors. And as mentioned, a key feature of safety 2, resilience and adaptability, is also critical team behavior, and we're gaining an increasing understanding of the impact of human factors, as Dr. Chang mentioned, in modifying perioperative risk. So I work at a 356-bed level 1 trauma and transplant center. That's kind of a small hospital considering the size of most tertiary care places. We have approximately 25 anesthetizing locations on the adult side, and on any given day, 11 full-time faculty anesthesiologists with 2 to 3 locums staffing the ORs for what we really feel strongly about 2-to-1 coverage. We serve as the academic arm for SSM Health, which comprises of 24 hospitals throughout the Midwest. We've implemented the following continuum of training methods shown here. They include team steps and HRO training for leaders, focusing on task-specific training in response to adverse events and as part of our action plans, which in my opinion doesn't really teach teamwork as much as it serves the purpose of achieving compliance. We conduct simulation modules for malignant hyperthermia training and PACU codes so that team members learn to recognize roles and situations that require adaptability and that those may be modeled. But most of all, if this training is not repeated over time, it does not help facilitate continuous improvement. So we encourage a culture of regular team debriefings by following up with teams after safety events within a very short period of time. So despite these being the listed goals of our continuum of training, teamwork training methods, one of our biggest barriers to continuous improvement has been workforce issues. Put simply, our experience has been that although healthcare workers with short contracts may be often very talented and are dedicated to high quality patient care, they frequently have less invested in improving the processes and culture of the hospital or department they're spending the short time working in. And we see this with lower rates of adverse event reporting, short training times, limiting the ability to absorb safety processes, which brings me back to the point that perhaps our best opportunities in this climate are to focus teamwork building on the surgeon anesthesiologist dyad, particularly for high complexity surgery. We know from 2 recent population-based studies done by the same researchers on complex oncologic gastrointestinal surgery that increasing familiarity of the anesthesiologist with the surgical team improves outcomes. The researchers first showed this by looking at anesthesiologist volume and then studied the frequency of specific anesthesiologists and surgeon teams on decreasing 90-day major morbidity. And what they found was quite striking, that for each additional time that a surgeon and anesthesiologist worked together, the risk of morbidity was decreased by 5%. In this Medicare study of over 100,000 patients undergoing cardiac surgery, team familiarity was defined as the number of shared procedures between cardiac surgeons and an anesthesiologist within 6 months of each operation. And after comparing surgeon anesthesiologist dyads in the highest and lowest team familiarity groups, patients cared for by familiar teams had significantly better 30-day outcomes. These findings were replicated in yet another study of over 7,600 patients undergoing spine surgery, where increasing familiarity between surgeons and anesthesiologists conferred significant risk reductions for post-operative morbidity. And if outcomes are so influenced by familiarity, it probably comes as no surprise that anesthesiologists who are staffing multiple rooms in addition to a major inpatient surgery may have less opportunities for effective teamwork and communication with the surgical team. In this now well-known study of over 500,000 patients, increased staffing ratios were associated with greater mortality and morbidity for inpatient surgery. I will say we have to be practical about this as well. In most practices, it's simply not feasible to have dedicated teams. At our own hospital, we can provide dedicated support for cardiac and liver transplantation, but because of the small nature of our hospital, most anesthesiologists end up building some familiarity with most surgeons. In large surgical centers, neurosurgical or thoracic surgery patients cared for by dedicated neuroanesthesia or thoracic anesthesiologists may fare better, and so will the trainees who get to learn from seasoned experts and practitioners in that field. But over time, from the anesthesiologist perspective, does overspecialization or working in siloed areas or parts of the operating rooms in larger centers, does that impact their skills in other specialties? We don't actually have very good data or research into this, but it's actually a very interesting question. Consider emergencies like the one presented in the vignette, or an emergency VATS, where during the day we may be able to find an ENT or a thoracic anesthesiologist, but overnight may fall out the doorstep of a cross-covering OB anesthesiologist unfamiliar with the surgical team, or far removed from the routine placement of a double lumen tube. Supervision-based models are increasingly common and favored for their upfront cost savings to an institution. In these models of care, a single anesthesiologist supervises sometimes 12 CRNAs who are usually executing the anesthetic without an anesthesiologist physically present in the room for any of these major critical portions. That can include high-risk OB care. My wife actually worked in this model as an anesthesiologist. Anesthesiologists generally in this model are present to put out fires and evaluate patients preoperatively. But in contrast to our own 2-to-1 model of care, there are fewer opportunities in this model to have preoperative conversations about surgical concerns with your surgeon. And during crises, this staffing model may present barriers to serving effectively as a team leader directing care. This is actually the model at numerous community hospitals around the country, including many of our own SSM Health hospitals. So I propose taking a different approach to improving teamwork and the dynamics between surgeons and anesthesiologists for various practice types. In large medical direction practices, subspecialty skills refreshers with simulation training should be required for specialized team members, with additional surgeon anesthesiologist dyad frequency monitoring for in-house call pool members. In small medical direction practices like where I work, where the majority of anesthesiologists take overnight call, we propose routine dyad frequency tracking for all team members. We've taken an interesting approach to OR assignments where if conflicts arise between a surgeon and an anesthesiologist, that specific team is actually assigned to work together more frequently with intensive coaching to help improve dialogue and a collaborative team spirit. We actually monitor whether or not preoperative phone calls or discussions are happening between those two individuals. For our other colleagues in the health system working in medical supervision practices, the opportunities to build relationships in the operating rooms may be more limited, so we bring the focus actually more on intensive preoperative discussions with surgeons, building familiarity with comprehensive high reliability organizing, combined leadership training, and that includes team steps. So I'll conclude by mentioning that large volume surgical centers may have better success with fixed OR teams, which the evidence suggests yields much better patient outcomes for those undergoing high acuity surgery. In settings where anesthesiologists must keep up skills in a broad scope of practice, dyad frequency should be tracked to help improve team dynamics and familiarity. And when dysfunction is identified, teamwork training should be deployed, and this approach may require different angles depending on medical supervision or direction-based models. Thank you.